Hello, my name is Van de Keyser. I am a neuroradiologist working in Ghent University Hospital in Belgium, and welcome to this video on imaging anatomy of the pharynx. In this video, I'm going to talk about the anatomy of the pharynx as seen on imaging studies of the head and neck, and this presentation will consist of 4 parts. In the first part, I will talk about the general anatomy of the pharynx, the general structural organization of the pharynx, and then I will discuss the various components of the pharynx separately, namely the nasopharynx, the part of the pharynx behind the nasal cavity, the oropharynx, the part of the pharynx behind the oral cavity, and finally the larynx, my apologies, the hypopharynx, the part of the pharynx located behind the larynx. And let's remove the video screen because it's bothering me a little bit. So what exactly is the pharynx? Let's start with the general anatomy of the pharynx. The pharynx is basically a muscular tube. That's the best way to understand the pharynx, a muscular tube extending from the skull base to the cricoid. And it's basically a shared passageway for the digestive and the respiratory system. The pharynx will direct food from the oral cavity to the esophagus and will direct air from the nasal cavity and or the oral cavity to the larynx and the trachea. And as such, the pharynx is basically a crossroad for those very important and essential functions being respiration, speech, and swallowing. The pharynx can be located behind the oral cavity, which is the first part of the aerodigestive system, and the nasal cavity, which is the most proximal part of the respiratory system, and is also located in front of the larynx, which is the cartilaginous system located between the pharynx and the trachea. The part of the pharynx located behind the nasal cavity is called the nasopharynx, the part located behind the oral cavity is the oropharynx, and the part located behind the larynx is the hypopharynx. But I am repeating myself. Let's talk a little bit about the structural organization of the pharynx. As said, the pharynx can be considered a muscular tube, and its structure consists of 5 layers. The innermost layers are the mucosa, consisting of epithelial cells, and the submucosa, in which we will find connective tissue, some vessels, nerve endings, some lymphoid tissue. We have a muscular layer, and that has to be present because, as said, the pharynx is a muscular tube, and muscles are often surrounded by fascia because that allows the smooth movement of muscles when they contract in relation to the surrounding structures. And the innermost facial layer surrounding this muscular layer is called the Pharyngobasilar fascia, and the outermost facial layer is called the buccopharyngeal fascia. And these two are extremely important, despite the fact that we can't really see them on imaging, or not quite well, because these are very thin structures. They are very important to understand the organization and the function of the pharynx. Then located next to the pharynx, we find the parapharyngeal spaces, and located behind the pharynx, we have the retropharyngeal space, which all makes sense from a terminological point of view, I would say. Okay, let's talk a little bit more about the structural organization of the pharynx. I said we can consider it a tube, but it's basically a half-open tube. The anterior part of this tube is opened and communicates with the nasal cavity and the oral cavity, which of course makes sense. And this is a T1 weighted image of the head and neck at the level of the oropharynx. It is a T1 weighted sequence with gadolinium and fat suppression. And if we magnify the oropharynx a bit, and we're going to talk about the exact anatomy in detail later, but this is just to illustrate the structural organization, we can actually discern the various layers of the pharynx. The innermost enhancing part is the mucosa or submucosa, and as said, the pharynx is basically a half-open tube. And what we see here is a tongue base. Okay, so this is the tongue base. And then this is the oropharynx, and we see the enhancing mucosa and submucosa. And the layer underneath it, which has a signal intensity of muscles, is of course the muscular layer. And the fascia surrounding the muscular layer are of course not well visible on imaging, but we can infer their location. So between the mucosa and submucosa and the muscular layer, we have the Pharyngobasilar fascia, which is a very thick connective tissue sheet. And on the outer surface of the muscular layer, we find the more loosely organized and thinner buccopharyngeal fascia. Okay, let's talk a little bit more about those layers because it will help us understand anatomy and pathology. Let's first talk about the mucosa and the submucosa. Most disease processes involving the pharynx originate at the level of the mucosa and or the submucosa. So most primary pharyngeal diseases, and those are mostly infectious diseases, inflammatory diseases, and neoplastic diseases, originate in those layers. And depending on how aggressive the process is, it will extend through the facial layers to potentially involve surrounding neck spaces, but I'm getting ahead of myself. Let's first talk about the mucosa and submucosa. So we have the innermost layer, the mucosa, lined with epithelial cells. And because these are epithelial cells, the most frequent tumor of the pharynx is a squamous cell carcinoma, because these are squamous epithelial cells. Then underneath it, we have the submucosa, in which we will find some connective tissue, we can find vessels, small nerve endings, and also a lymphoid tissue. This explains why one of the tumor types we can find in the pharynx is oral lymphomas, because we have mucosa-associated lymphoid tissue in the submucosa, and we will also find in the submucosa minor salivary glands, and this explains why another tumor type that can be encountered in the pharynx are the aggressive and malignant minor salivary gland tumors. Finally, already mentioned, we have some connective tissue and vessels over there. Let's talk a little bit more about the lymphoid tissue we can encounter in the pharynx. The lymphoid tissue in the pharynx is organized in a ring, which is called Waldeyer's ring. I hope I pronounce it correctly. Maybe it's Waldeyer's ring, I don't know. And these are basically aggregates of lymphoid tissue located in the submucosa immediately underneath the mucosa, which surround the pharyngeal entrance. And we need lymphoid tissue there because, well, we call it the pharyngeal entrance. This is an entrance area for food, for water, for air into our body, and these substances will contain a lot of pathogens. So we need a first line of defense, of immunological defense against these inhaled or ingested pathogens, and that is what Waldeyer's ring is for. Is it relevant? Yes, otherwise I wouldn't mention this here. Why? Because in children who are continuously exposed to pathogens and in whom the immune system is being developed, we will often find hyperplasia of these lymphoid structures, and that can be visible on imaging. And it's important to know that, to not confuse it with pathology. And we can also find infectious processes over here because, well, that's the area where pathogens are attacked. So we can get infections there, and even tumors. So, okay, it's important to be aware of these structures. And what kind or where exactly do we find lymphoid tissue in the pharynx? Well, basically in the naso and oropharynx. We will find it in the midline of the nasopharynx, where we call it the nasopharyngeal adenoids, and also surrounding the orifice of the Eustachian tube, which opens in the nasopharynx, and the lymphoid tissue located over there is called the tubal tonsils. At the level of the oropharynx, we find the palatine tonsils, and at the level of the tongue base, we find the lingual tonsils. Let this drawing not mistake you. The palatine tonsils are located laterally and the oropharynx, and this is a mid-sagittal drawing, so it was not possible for me to draw them laterally on the oropharynx, so this is a simplification, but it helps you understand the organization of Waldeyer's ring. Okay, let's now talk about the muscular layer because the pharynx is, as said, a muscular tube after all. The muscular layer consists of two types of muscles, or in the muscular layer, we find two types of muscles. The muscles that are located, the outermost located muscles, or the so-called outer circular constrictor muscles. And then we have several inner longitudinal muscles, which are located on the inner side of these constrictor muscles. So this makes sense. What are these constrictor muscles exactly? Well, we have three of them and they kind of overlap. They originate at the skull base and then they insert at various points along the pharynx. And we have a superior constrictor muscle, a middle constrictor muscle, and an inferior constrictor muscle. And these kind of envelop the tube or the half open tube that is the pharynx. So they are C-shaped. We have a superior, middle, and inferior one, and they are somewhat interwoven. They overlap one another, but there are also small gaps in between them. So we have areas where the muscle isn't quite as dense or even absent. And what happens when these contract, we get narrowing of the pharynx. And we will first get contraction of the superior constrictor muscle, then of the middle, then of the inferior. So we basically get a sequential narrowing of the pharynx, and this will push food down from the esophagus, from the oral cavity into the esophagus. Now, what do the inner longitudinal muscles do? We have three of them. So they are located on the inner side of the constrictor muscles. And we have the stylopharyngeus, the salpingopharyngeus, and the palatopharyngeus. The first term in their names refers to their point of origin. So the stylopharyngeus originates from the styloid process, the salpingopharyngeus from the Eustachian tube, and the palatopharyngeus from the soft palate. What happens when these contract? Well, you can kind of visualize it. If this muscle would contract, you will get an elevation of the pharynx, which will shorten the pharynx and might also locally widen it a bit, but it will mainly shorten the pharynx. So this elevation of this shortening of the pharynx and elevation of the larynx will make space for the food bolus and also make the pharynx accept the food bolus that is being pushed down by the constricting constrictor muscles. When it comes to the organization of the muscle layer, we can kind of visualize it as a set of open cardboard boxes that are stacked inside one another, with the uppermost box being the Pharyngobasilar fascia, the very dense connective tissue sheet located between mucosa, submucosa, and the muscular layer, and which is basically some kind of inner skeleton for the entire pharynx, and on which around which the constrictor muscles are draped. Then we first have the superior constrictor muscle, followed by the middle constrictor muscle and the inferior constrictor muscle. And as such, these are can be seen as stacked inside one another. Then they insert at the level of the skull base, but we also have only limited coverage of the constrictor muscles at the level of the skull base. So the Pharyngobasilar fascia at the level of the nasopharynx will constitute a lot of the wall of the pharynx at that level. And the most distal point is the cricoid cartilage, where basically the pharynx transitions into the esophagus below this level, so to say. Then on the inferior side, we find the longitudinal muscles like the salpingopharyngeus, stylopharyngeus, and palatopharyngeus, as said. Now, what happens when we swallow? I already explained it, but these drawings will maybe help you visualize what I said, because I'm not sure if I explained it quite clearly. What happens when we swallow? Well, we get, first of all, these processes happen simultaneously, but we get a sequential constriction or contraction rather of the pharyngeal constrictor muscles. So first the superior will contract, then the middle, and then the inferior muscle. And this basically narrows the tube and pushes food downwards, and simultaneously the contraction of the longitudinal muscles will shorten the pharynx. So what we get if we combine these two processes is something that looks like this. So of course this is a bit of an exaggerated drawing just to make the process clear, and this all happens simultaneously. So if we do a swallowing examination with barium, it's not like we can really discern the contraction of the various muscles. It all happens too fast and too quickly, but that's basically what happens when we swallow. Okay, we talked about the mucosa and the submucosa, we talked about the muscular layer, and then we have the Pharyngobasilar fascia located between the two. And despite the fact that this layer is not very clearly visible, sometimes you can see a small T2 hypointense line on MRI, but in a lot of cases you can't really see it. It's nevertheless an important one. This is a very dense connective tissue layer. It reinforces the pharyngeal wall where the muscular layer is absent or thin, like for instance at the level of the skull base, where there is only partial coverage by the superior constrictor muscle. And functionally, this also, or from a pathological point of view, this is also an important layer because it functions as a barrier for the spread of infections and tumors. So most of these originate in the mucosa or submucosa, and to infiltrate the head and neck, to infiltrate from the pharynx to the other neck spaces, they have to go through the Pharyngobasilar fascia. So when you have a process extending from the pharynx into the neighboring neck spaces, it means it penetrated the Pharyngobasilar fascia, and in that case, it has to be something that is quite aggressive, because something that isn't aggressive or is benign won't be able to do that. Okay, the Pharyngobasilar fascia was already drawn, already shown in this drawing. So it goes from the skull base all the way down along the pharynx, and as said, can be seen as the inner skeleton of the pharyngeal wall, a very tough fibrous layer stretching from the skull base downwards, providing structural support where the muscles are thin and absent, and is an important barrier for the spread of disease. It's also important to understand the insertion of the Pharyngobasilar fascia on the skull base. Why is that? If you have a disease involving the pharynx, well, the pharynx is located underneath the skull base. You have a lot of openings in the skull base for vessels and nerves called foramina. And if you have a disease process in the pharynx, what's stopping the disease from entering the skull and spreading intracranially? Well, it is the Pharyngobasilar fascia. Let's illustrate this. Here we see the clivus, the petrous bone, and the sphenoid, which are major bones forming part of the skull base. And we are looking from outside at the skull base. And if we look at this magnified view, we see various openings. Important ones are the carotid foramen, which is an opening for the internal carotid artery, where the internal carotid artery will enter the skull. We have the foramen lacerum, which is basically not a real foramen because nothing important passes through the foramen lacerum. It's just an opening in the skull base located between the clivus, the sphenoid, and the petrous bone. It's often filled with cartilage, but it's still an opening there, so could function as an opening allowing the spread of disease into the cranium. And then we also have, here comes my Pharyngobasilar fascia. So the Pharyngobasilar fascia inserts at the skull base on the pharyngeal tubercle of the clivus. Then it inserts on the petrous bone, medially and anteriorly of the carotid foramen. So the carotid foramen is located outside of the Pharyngobasilar fascia, and then it inserts on the medial pterygoid or the medial pterygoid plate rather. And you will see that all these neuroforamina, also this one, the foramen ovale, for the mandibular nerve of the trigeminal nerve, or the mandibular branch of the trigeminal nerve rather, and the foramen spinosum for the middle meningeal artery and vein, that these are also located outside of the Pharyngobasilar fascia. The foramen lacerum is covered by the Pharyngobasilar fascia. So basically, for any disease in the pharynx, specifically in the nasopharynx, to enter the cranium, it would have to penetrate the Pharyngobasilar fascia before it can enter the cranium through any one of these skull base foramina. And that is very important to keep in mind, especially when looking at pathology. So here are once again the insertions of the Pharyngobasilar fascia on the skull base. This is the pharyngeal tubercle of the clivus. Then it inserts on the petrous bone, more specifically at the level of the petro-occipital suture, making a turn medially and in front of the carotid foramen. And finally, we get an insertion at the medial plate of the pterygoid. So it's located anteromedially of the carotid canal and seals off the foramen lacerum as said. This is the pharyngeal tubercle of the clivus. So this is the point of insertion for the Pharyngobasilar fascia. And this is just an illustration on CT and bone kernel of the medial pterygoid plate. So despite the fact that we can't really visualize the Pharyngobasilar fascia, we can visualize the structures on which it originates or on which it inserts, and as such, kind of infer its location. Then the final fascia we have to talk about is the buccopharyngeal fascia, which is the outermost layer, so located on the outside of the muscular layer. So it covers the constrictor muscles and also contains the neurovascular plexus of the pharynx. So we also find nerves and vessels inside this facial layer, or entering this facial layer. This forms the anterior border of the retropharyngeal space, and the buccopharyngeal fascia is very thin and loose, as already said, so this more easily allows the spread of infections to other planes, and in this case, the retropharyngeal space. And as you know, from the retropharyngeal space, the disease processes can potentially also reach the danger space and extend into the mediastinum. If your knowledge of these neck spaces is not what it used to be, or you don't really know these that well, there are also videos on this channel discussing the anatomy of the neck spaces. The functional role of the buccopharyngeal fascia is to allow smooth movement of the pharynx during swallowing and speech. And with that, I think we are ready to talk about imaging anatomy in more detail of the various structures. Let's look at a sagittal CT image. Let's repeat once again, we have a nasal cavity and oral cavity, and the detail of these cavities is already discussed in detail in other videos on this channel. What I'm going to talk about now is the anatomy of the pharynx, the structure that connects the nasal and oral cavity with the esophagus, respectively with the larynx, and from the larynx there's a connection with the trachea and the lungs, of course. And well, we already said this, we can subdivide the pharynx in a nasopharynx, oropharynx, and a hypopharynx, and this is what these look like on CT. So they have a quite conspicuous morphology, I believe, on CT images, and this morphology is caused by very specific structures. So without much further ado, let's start with part 2 of our discussion on imaging anatomy of the pharynx, and let's talk about nasopharyngeal anatomy. Okay, hello and welcome to part 2 of imaging of the pharynx, the nasopharynx. What is the nasopharynx? The nasopharynx is the uppermost part of the pharynx. It is located behind the nasal cavity and above the soft palate and the oropharynx, and it functions as a passageway for air to the respiratory system. That's not the only function it has, but it's basically definitely the most important one. Other functions of the nasopharynx are it plays a role in middle ear ventilation, because as mentioned in the previous part, the orifices of the Eustachian tube are located in the nasopharynx, and when these open, our middle ear gets ventilated, so middle ear ventilation. Voice resonance, the presence of this let's call it chamber and the upper pharynx behind the nasal cavity contributes to the resonance of our voice. And it has an immunological function because we have lymphoid tissue here located in the nasopharyngeal adenoids and the tubal tonsils. What are the borders of the nasopharynx? Anatomically, when do we start calling something this is inside the nasopharynx? The anterior border of the nasopharynx is a so-called choana. What is the choana? The choana basically refers to the aperture posteriorly of the nasal cavity. So we have the nasal cavity, and I'm also going to illustrate the choana on an axial image. The choana is basically the posterior opening. So we have bony structures constituting the walls of the choana, and part of those are the posterior spine of the hard palate, the sphenoid bone of the skull base, and the pterygoid plates, the medial pterygoid plates, and also the bony nose septum. And these divide the choana in two parts. So we have two openings here located posteriorly of the nasal cavity. And these form the border to the anterior border to the nasopharynx. The superior border is formed by the skull base, the sphenoid bone, and part of the clivus, and the inferior border is formed by the superior surface of the soft palate. The soft palate belongs to the oropharynx, not to the nasopharynx, which is also important to know. Then finally, the posterior border is formed by the posterior wall of the nasopharynx, and the lateral borders are formed by the lateral walls. And these are mucosal surfaces, so mucosal surfaces lining the nasopharynx. Okay, on these images, I'm still talking about the borders of the nasopharynx because repetition is the mother of all learning. So this is once again the anterior border, but this time it's a big image filling most of your screen. So this is the choana, this is the posterior nasopharyngeal wall. Here we have the skull base aligned with mucosa. We have the inferior surface formed by the soft palate. And here in the axial plane, we can also see the choana, the posterior pharyngeal wall, but also the lateral pharyngeal walls. We're still talking about the borders of the nasopharynx, I believe. These are the lateral pharyngeal walls, and this is the posterior pharyngeal wall. Let's magnify this a bit. And what is very conspicuous and always visible when talking about on images of the nasopharynx, that are like these elevations or protrusions, or how would you call them? We have two of them on each side, so one of them on each side, so two in total, along the lateral nasopharyngeal walls. And these protrusions we call the Torus Tubarius, and I'm going to explain in a minute what that is exactly or what is causing it. And we have these two elevations along the posterior pharyngeal wall, and these elevations are caused by underlying muscles which are not part of the nasopharynx, but are located in the prevertebral space. And these muscles are, depending on the height, the longus capiti or longus colli muscles, or a combination of both. So here I call them the longus capiti. Longus capiti is located immediately underneath the skull base, and the longus colli is located a bit lower anteriorly of the cervical vertebra. Okay, so we have these very conspicuous landmarks, or anatomical landmarks, so to say, which we can always see in a normal nasopharynx on imaging studies. This is a T1 weighted image with gadolinium and fat saturation. And if you magnify it a bit, we clearly see the Torus Tubarius, once again, laterally or along the lateral nasopharyngeal walls. And posteriorly, we see the longus capiti / colli muscles causing these elevations of the posterior nasopharyngeal wall. And remember, these are located in another neck space, namely the prevertebral space. The Torus Tubarius, however, is located inside the nasopharynx. This is a magnified coronal image. Can look a bit strange because I magnified it and it's difficult to recognize the structures, but this is the nasopharynx. Here, on top of that, we have the sphenoid sinus, and on top of the sphenoid sinus, we have the pituitary. Do you recognize everything now? Okay, fine. Let's now magnify the nasopharynx. We clearly recognize the roof, which is formed by enhancing mucosa located along the border of the skull base, and we have two lateral nasopharyngeal walls also lined with contrast-enhancing mucosa. The point of this slide is that the Torus Tubarius can also be recognized, this elevation, in coronal images because the Torus Tubarius slopes downward a bit. Okay, now, final question, what is the Torus Tubarius exactly? Or where is it located? Well, I already told you that. So here we see the internal carotid artery, right? This is the medial pterygoid plate, right? And remember, in the previous presentation, we've seen the location or discussed the location of the Pharyngobasilar fascia. So the Pharyngobasilar fascia is the thick fascia located superficially of the constrictor muscles or the muscular layer of the pharynx. And basically, it originates at the skull base at the level of the pharyngeal tubercle of the clivus and along the petrous bone, and it makes a turn anteriorly in front of the canal for the internal carotid artery to insert on the medial pterygoid plate. Right? So the longus colli muscle is located outside the pharynx, so it's located outside the Pharyngobasilar fascia, but the Torus Tubarius is located inside the nasopharynx, as I already told you. And what is it exactly? Well, the Torus Tubarius is an elevation of the lateral mucosa of the nasopharynx caused by the Eustachian tube and a specific muscle called the Levator veli palatini muscle. And where do these come from? Well, these come from outside the nasopharynx. They originate at the level of the temporal bone, but they penetrate the Pharyngobasilar fascia in a small gap called the Morgagni sinus. So this is a small gap located posterolaterally in the Pharyngobasilar fascia to allow the Eustachian tube and the Levator veli palatini muscle to enter the nasopharynx. The Torus Tubarius, as said, is the most prominent superficial landmark of the nasopharynx. So if you see this image, you immediately recognize that we are looking at the nasopharynx. You don't have to be able to visualize all the borders because you immediately see the Torus Tubarius causing an impression here, and also the elevation caused by the longus capiti / colli muscles. So it's a mucosal elevation caused by the Eustachian tube, as said. And anteriorly of this elevation, we find the ostium of the Eustachian tube, so an opening for the Eustachian tube in the nasopharynx. And posteriorly, we find a mucosal recess called the Rosenmüller fossa. And this is a very common site for nasopharyngeal carcinomas. So a lot of nasopharyngeal carcinomas originate in this specific mucosal recess. So it's definitely one you want to inspect or scrutinize on imaging studies, and it's definitely a must-know structure. Let's talk a little bit more about the Eustachian tube, because it's an important structure to know, despite the fact that we can't really see it that well, or we have to infer its location on imaging studies. I compared a magnified axial T2 weighted image at the level of the nasopharynx with a pathological specimen. And I think on both we can clearly recognize the Torus Tubarius and the nasopharynx. On the pathological specimen, we see a very thin line extending from the nasopharynx to the temporal bone located over here. This is the Eustachian tube, a canal connecting the tympanic cavity and the temporal bone with the nasopharynx. And it consists of a quite long anterior cartilaginous part and a much smaller bony part called the protympanum. And we can't really see these structures on an MRI image, but we know they have to be there. Then we have the ostium, or the opening, located anteriorly of the Torus Tubarius, and the Torus Tubarius itself is caused by cartilage. And the cartilage lining the walls of the Eustachian tube, on that cartilage, specific muscles will insert, and by pulling away the cartilage, they can open the ostium and widen the Eustachian tube. But I will explain how that works in a minute. This is a drawing I once made for a presentation on the temporal bone and was useful for this presentation as well. We see here the Eustachian tube connecting the tympanic cavity with the nasopharynx, which I couldn't draw on this image. And as said, the Eustachian tube has two parts, a fixed bony part, a small one called the protympanum, and a longer anterior part lined with cartilage called the cartilaginous part. Let's move on to a CT image. On this image, we see here the fixed bony part, the protympanum, which is located anteriorly of the hypotympanum of the temporal bone. And on this CT image, we can even see the cartilaginous part. This is the bony part, the protympanum, but here we see the Torus Tubarius, and we see a line filled with air located anteriorly of the Torus Tubarius. This is the cartilaginous Eustachian tube, and we see air in it. That's not normal. You shouldn't be able to see air in the cartilaginous part of the Eustachian tube on a CT image. This is called a tuba apertura or a patulous Eustachian tube. It's basically a dysfunctional Eustachian tube, and it's continuously a bit open, which is why we are able to see this streak of air aligning its lumen or exposing or making its lumen visible. Normally, that's not the case. On MRI, we can't really see the cartilaginous the lumen rather of the Eustachian tube. What we often see are these very hyperintense components in the Torus Tubarius, and I believe that these correspond to the cartilage lining the Eustachian tube, but I'm not sure because I didn't find a convincing study linking the MRI appearance with pathology. If you know of such a study, please let me know. So when I say I think it is cartilage, that's just my personal opinion. I don't have any real proof for that statement. But what is more important, you will often see that the Torus Tubarius has this very hyperintense component on T2 weighted images, which even further helps you to detect the Torus Tubarius and to visualize it. The Eustachian tube, as already said, is a narrow canal connecting the tympanic cavity with the nasopharynx. And why do we have that canal? Well, it is responsible for equalizing the pressure between the tympanic cavity and the nasopharynx. When do we notice that we have an Eustachian tube? When we are in an airplane that is ascending or descending, because then we get a sudden difference in a sudden gradient in the atmospheric pressure and the pressure in our tympanic cavity. And by swallowing, we open the Eustachian tube and the pressure equalizes. And that removes the strange feeling we get when our tympanic cavity gets retracted inside our eardrum rather gets retracted inside the tympanic cavity due to the difference in pressure between those two structures. And it's also responsible for the drainage of secretions from the tympanic cavity into the nasopharynx. As said, we have two muscles that are quite important for opening the Eustachian tube, and these are called the Levator veli palatini and the Tensor veli palatini. Let's magnify this coronal image. I hope you recognize the nasopharynx. This here is the nasopharynx. And we see here this quite hyperintense structure on these T2 weighted images. This is once again the Torus Tubarius. We can also recognize, I believe, the morphology of the Torus Tubarius over here. And that combined with the typical T2 hyperintense aspect, maybe corresponding to the cartilage, makes it a very recognizable structure. And we see a muscular structure located underneath it, coursing from the undersurface of the cartilaginous part of the Eustachian tube to the soft palate. This is the soft palate, and this is the Levator veli palatini muscle, whose main function is actually elevation of the soft palate, hence its name, Levator, a lifter of the veli palatini, of the soft palate. We also have another muscle, this very fine line. Oops. Oh, I forgot to mark it. We also have this very fine line located laterally of the Levator veli palatini and the cartilaginous part of the Eustachian tube, and this is the Tensor veli palatini muscle. Let's go to the next slide. Here I made a drawing. So this is the cavity of the nasopharynx. Here we see the cartilage of the Eustachian tube lining the lumen of the Eustachian tube. Here we have the marked in blue Levator veli palatini muscle coursing towards the soft palate, and I drew it for you over here. And here, this muscle is the tensor veli palatini. So I drew it also for you over here. And the tensor veli palatini tenses the soft palate, so also plays a role in the elevation of the soft palate. But of these two muscles, the tensor veli palatini is probably the most important one for the opening of the Eustachian tube. And how does that function exactly? Well, let's just visualize it because that will make it clear. So normally we have the lumen of the Eustachian tube is surrounded by cartilage, and this cartilage is like C-shaped or hook-shaped if you want. We have the levator veli palatini inserting on the medio-inferior part of the cartilage, and we have the tensor veli palatini inserting on the smaller lateral hook of the cartilage. When these muscles contract, what do you get? You basically get the cartilage being pulled open, so to speak, and as a consequence, the lumen being pulled open, and then we get an opening of the Eustachian tube. So these muscles play a role in the elevation of the soft palate, and when we swallow, the soft palate elevates. It closes off the nasal cavity, so you can't get regurgitation of the contents from your oral cavity inside your nasal cavity. And at the same time, as a soft palate elevates, we get an opening of the Eustachian tube, and we get equalization of pressure between the nasopharynx and the tympanic cavity, and also drainage of secretions. Okay, can we recognize these muscles on imaging? Yes, we can. We've already seen them on coronal images, but admittedly, it's not that easy on coronal images. It's a bit easier on axial images. So let's look at these magnified images of the nasopharynx. Here we have the Torus Tubarius with a hyperintense, presumably cartilage located in the center. And behind it, we see the levator veli palatini muscle. And once we found it, we just have to follow our images. So if we scroll down, we can consistently see the levator veli palatini coursing downwards until we reach the soft palate located over here. So this is a soft palate. And the levator veli palatini basically forms a sling with its contralateral part. And this sling basically elevates the soft palate when it is contracted. Can we also recognize the tensor veli palatini? Yes, it's a much smaller muscle, but we can recognize it as well. Let's start with this point of reference. This is the Torus Tubarius. Here we see the levator veli palatini muscle located behind it, and the tensor veli palatini muscle is located laterally of the Torus Tubarius and the levator veli palatini. So it is this very thin line laterally of those other muscles. If we then scroll up and down, we just have to follow this structure, and we know, whoops, what happened, where the tensor veli palatini is. Here it is. If we scroll one image up, and if we now scroll down, we can follow it all the way to the level of the, look at the arrows. This is the medial plate of the pterygoid bone. And here it does not insert, but it makes a hook, and then it turns medially to insert on the aponeurosis of the soft palate, but that is something that is not easy to recognize on images. So we can just, well, I can just see the component coursing towards the medial pterygoid plates. The component that then inserts on the soft palate is not something, and I did my best, something I can really put into view. But it's also not that important. I think it's more important that you are able to recognize these muscles on axial images, and when you're dealing with a nasopharyngeal tumor, then you can make statements about whether or not these tumors are invaded also, but I believe that suffices from a diagnostic point of view. This image is angulated in such a way that it very nicely shows you the relationship of these muscles to the Torus Tubarius, with the levator veli palatini located underneath it and behind it, and the tensor veli palatini laterally of it. Also notice that we have a very thin stripe of fatty tissue between the tensor veli palatini muscle and the levator veli palatini muscle. We can also recognize that on these actual T1 weighted images. It's T1 hyperintense, so this is fat, and this is called Ostman's fat patch. And it's something that you can actually recognize if you look for it, despite the fact that it's very thin and very small. It's something that you can consistently recognize on MRI images. Okay, that's it when it comes to anatomy of the nasopharynx. I'm not going to go into detail on nasopharyngeal pathology. That will be for another presentation. This is just about anatomy, but I'm just going to give you some generalities on pathology. I think there are two things you have to know now at the moment. First of all, you have to be able to recognize nasopharyngeal adenoid hypertrophy to avoid mistaking it for pathology. And you have to be able to recognize a nasopharyngeal carcinoma, which is the most frequent tumor originating primarily in the nasopharynx. What is nasopharyngeal adenoid hypertrophy? We've seen a lot of images of the nasopharynx, and we now recognize the typical morphology of the Torus Tubarius and also, the classical impressions caused on the posterior wall by the longus capiti and colli muscles. But in children, the nasopharynx often looks obliterated by a soft tissue structure, and we get something that looks like this. And this structure can persist, but generally decreases with increasing age until and most adults it's gone. It has disappeared. Sometimes it persists, maybe for instance in smokers or HIV patients, but in most patients it's gone. This is nasopharyngeal adenoid hyperplasia. It looks very symmetrical. There is no infiltration of the surrounding neck spaces, so this entity is completely confined within the nasopharynx, and most patients are children, or we most frequently see it in children. What is it? It's basically hyperplasia of the nasopharyngeal adenoids and the tubal tonsils. So we already talked about the lymphoid tissue located in the submucosa of the pharynx in more detail in the previous part on imaging anatomy of the pharynx. And in children, due to chronic exposure to pollutants, to pathogens, and so forth, this lymphoid tissue can become chronically stimulated and become hyperplastic. And this is very common in children. So then we get this soft tissue structure located in the roof and along the posterior walls of the nasopharynx, and it will decrease as children get older and is generally gone in adolescents and adults. Exceptions being, as said, smokers, because these keep stimulating the lymphoid tissue in the nasopharynx, and HIV patients. Okay, is this important from a pathological point of view? Well, you just have to recognize it as something that is very frequent in children. It can cause symptoms, but it's not up to radiologists to make a statement about that, unless you have seen the patients clinically and you know what you're talking about when it comes to the symptoms of the patient. But you will also see that a lot of these children on imaging studies will have an opacification of the middle ear and or mastoid. And why is that? Well, I said to you that the Eustachian tube is responsible for the drainage of secretions from the mastoid and middle ear into the nasopharynx. Here we see the Eustachian tube dilated and filled with fluid, and we can follow it all the way to the presumed orifice of the Eustachian tube, and there is an obstruction of the orifice by this hyperplastic nasopharyngeal adenoid tissue. And this can cause chronic middle ear and mastoid effusions. Patients can have, or children can have, conductive hearing loss as a consequence of that, and you are more prone to repeated infections of the middle ear. And in those cases, this nasopharyngeal hypertrophy becomes a cause of pathology. So it can be an incidental finding in asymptomatic patients or a cause of symptoms. Then, what do you also have to recognize in adults? That is a nasopharyngeal carcinoma. If you see a unilateral mastoid effusion in an adult, take-home message, always check the nasopharynx, because we now know that the middle ear and the mastoid air cells get drained by the Eustachian tube, and the orifice is in the nasopharynx. So if you get a tumor there that obstructs the Eustachian tube orifice, well, then you will get a unilateral mastoid effusion and or opacification. So check the nasopharynx, and on this actual T1 weighted image with FATSAT and gadolinium, we see a large tumor located on the right side of the nasopharynx. So check the nasopharynx, and if you're looking for small tumors, check Rosenmüller's fossa, because this is the predilection site for the development of nasopharyngeal cancer. And here we see several magnified views of the nasopharynx, and we see small tumors located in Rosenmüller's fossa in each and every one of these patients. So see them over here. And this is a large tumor which has infiltrated the prevertebral space. So we see infiltration of the longus colli muscles over here and also of the parapharyngeal space. So this was a larger nasopharyngeal tumor, but I have a draft on staging of nasopharyngeal cancer, so that will be for a future video. This concludes introduction to imaging anatomy of the nasopharynx. Let's get ready for part 2, imaging anatomy of the oropharynx. Hello and welcome to the third part of our videos on imaging anatomy of the pharynx, and this video will be about the oropharynx. The oropharynx is the middle part of the pharynx. It is located behind the oral cavity, and it extends from the soft palate, which is part of the oropharynx, to the lingual border, so the side of the epiglottis facing the tongue base, the lingual border of the epiglottis. The epiglottis is not part of the oropharynx. The epiglottis is not part of the pharynx at all. It is part of the larynx, which is maybe not unimportant to keep in mind. The nasopharynx is located above the oropharynx because it is the middle part of the pharynx, and the hypopharynx is located underneath it. So this is all quite easy. And the oropharynx is the middle part, and it serves as a common passageway for food and air to the esophagus, respectively to the larynx, and from the larynx to the trachea and the lungs. The anterior border of the oropharynx, so basically the border between the oral cavity and the oropharynx, is formed by the oropharyngeal isthmus, which is basically the gap you see at the back of your throat when you say ah. So this is a drawing of the oropharyngeal isthmus generated by ChatGPT, and I must say anatomically quite accurate. So the number of teeth is not completely correct, but those are details and they don't jump to the eye, I must say. Let's use this drawing to illustrate the anatomy of the oropharyngeal isthmus and understand the borders between the oral cavity and the oropharynx. So as said, it is the gateway connecting oral cavity with oropharynx, and the superior border is formed by the uvula of the soft palate, the inferior border by the tongue base, more specifically by the circumvallate papillae, and I'm going to talk about those on the next slide, and then the lateral border is formed by the anterior tonsillar pillars. And when we have anterior tonsillar pillars, we also have posterior ones, of course, but more about that later. For now, it suffices to understand the anatomy of the oropharyngeal isthmus. The oropharyngeal isthmus, the inferior border is by the tongue, more specifically by a recess located behind the circumvallate papillae. We call this recess the terminal sulcus, and the circumvallate papillae are about 8 to 12 large papillae containing taste buds, especially for bitter taste, and which are arranged in some kind of V shape. This drawing is not completely accurate because that V shape has an apex pointing posteriorly, not anteriorly, but the drawing suffices to basically understand the anatomy. And this recess, the terminal sulcus behind the circumvallate papillae, forms or marks the border between the oral tongue located anteriorly of it and the tongue base located posteriorly of it. So the tongue has two components, the oral tongue located in the oral cavity and the tongue base, the posterior third, located in the oropharynx. Let's now talk or illustrate the borders of the oropharynx. The anterior border I've shown you, and the anterior border is actually quite clearly visible when you say ah and look in someone's throat, but not clearly visible on sagittal CT images. We have to infer its location, and we do that by drawing a line from the boundary between the hard palate and the soft palate to the tongue base and the hyoid, as I've done on this image. So, okay, you're going to see this on each CT image on this slide, and this marks the oropharyngeal isthmus, or the presumed location of it. Then the superior border of the oropharynx is formed by the soft palate, and the soft palate is part of the oropharynx, as already said. The inferior border is formed by the lingual surface and the tip of the epiglottis, which is not part of the oropharynx. The posterior border is formed by the posterior oropharyngeal wall, and the lateral borders are formed, and here we see the posterior pharyngeal wall on a magnified axial CT image, and the lateral borders are formed by the lateral pharyngeal walls at the level of the tonsillar region. Okay, let's now also examine the borders on somewhat larger images. So this is the soft palate, or the superior border. Here we have the epiglottis, and the lingual surface of the suprahyoid epiglottis, so the part located above the hyoid, marks the inferior border. Here we have the oropharyngeal isthmus, the anterior border, and this is the posterior pharyngeal wall. On a coronal image, we can also see part of the soft palate. This is the uvula of the soft palate, and we can even see part of the epiglottis. So now we have an approximation of the superior and inferior border of the oropharynx, and these are the lateral pharyngeal walls of the oropharynx located between the soft palate and the epiglottis. Finally, let's examine the borders on a large axial image. We clearly see the lateral pharyngeal walls, and this is the posterior pharyngeal wall. And this here is the tongue base, which is, as said, part of the oropharynx, not of the oral cavity. From an oncological point of view, the oropharynx is subdivided in specific subsites. Those are the tongue base, we have the soft palate, we have the tonsillar regions, and we have the posterior wall. And I'm now going to discuss the anatomy of these specific subsites in the rest of this presentation. Let's start with the tonsillar region. You've already seen this illustration, and I've told you then that when you have anterior tonsillar pillars, and what are those? These are basically mucosal folds covering a specific muscle, the palatoglossus muscle. When you have anterior tonsillar pillars, you also have posterior tonsillar pillars, and the posterior tonsillar pillars are also mucosal folds covering a specific muscle, namely the palatopharyngeal muscle, or the palatopharyngeus muscle. Then we have a fossa between these pillars, which we call the tonsillar fossa, and in the tonsillar fossa we find lymphoid tissue, the so-called palatine tonsils. And the palatine tonsils, and this is often the case for lymphoid tissue and the pharynx, they can be enlarged or quite prominent in children, but they tend to become smaller and smaller as we age, and we see very little of those anymore in most adults. Let's now try to recognize these specific structures on an axial MRI image. This is an axial T2 weighted image. This is the uvula of the soft palate. So let's remove the coloring. Okay. And next to the uvula, we see two soft tissue structures. These are the palatine tonsils located in the tonsillar fossa. We see an X shape. Yeah, we see these. We see two arms of the letter X going to and from the uvula. What are those? These are the anterior and posterior tonsillar pillars. The anterior tonsillar pillars are, as already said, basically mucosa lining a specific muscle, the palatoglossus muscle, and the palatoglossus muscle goes from the soft palate to the glossus, the tongue, as we can actually see on this image. And the posterior tonsillar pillars are formed by the palatopharyngeus muscle, which go also from the soft palate to the posterior pharyngeal wall, as you can see here. So this all makes sense, doesn't it? Then we have this muscle over here lining the lateral part of the palatine tonsil. What muscle is that? This is the superior, depending on the level you're looking at, could also be the middle, but probably the superior constrictor muscle over here. And this is, and the superior constrictor muscle not only forms the lateral wall of the tonsillar fossa, but also runs in the posterior pharyngeal wall. So this is the superior and or middle constrictor muscle. I magnified this a bit to make it even more clear. I'm going to repeat it completely because that's the best way for you to learn. Well, I don't know if it's the best way for you to learn. It's the best way for me to learn. Once again, we see the uvula, we see the tonsillar fossa, and we see these muscles coursing towards the tongue and the posterior pharynx respectively, and these are the palatoglossus and palatopharyngeal muscle. And once again, here we have the superior constrictor muscle running in the posterior pharyngeal wall and laterally of the tonsillar capsule. Now, this is a structure we can't see, but the palatine tonsils actually have some kind of capsular lining, a hemicapsule lining the lateral wall. And between the muscular layer, so the superior constrictor muscle or middle constrictor muscle, whatever, which is surrounded by fascia, by the way, and the tonsillar hemicapsule, we have a space called the peritonsillar space. Now, despite the fact that we can't really recognize that very small space on images, it is nevertheless, from a pathological point of view, an important space. Why is that? Well, when a person has a tonsillitis complicated by an abscess, we don't call it a tonsillar abscess, we call it a peritonsillar abscess. Ever wonder why? That's because pathologically these abscesses do not arise inside the palatine tonsil, but in the peritonsillar space. Hence the name, hence why I'm illustrating this, despite the fact that, as said, we can't really recognize it on images. What we can recognize, and what I'm going to repeat once again by showing you a magnified axial T1 weighted image with gadolinium and fat saturation, or the uvula, we have the tonsillar region with the palatine tonsils, and it's not so nicely visible as on the T2 weighted images, but nevertheless, if we take some trouble, we can recognize this muscle over here, which is the anterior tonsillar pillar with the palatoglossus, and we have this posterior tonsillar pillar over here with the palatopharyngeus. And final image to illustrate the anatomy of the tonsillar region. Once again, we see an axial T2 weighted image with fat sat, the uvula. We see the X formed by the anterior and posterior tonsillar pillar with the palatoglossus and palatopharyngeus lining the palatine tonsil. And on this sagittal T1 weighted image, we can even see this X, well, it's not an X, in the sagittal plane, we can see these muscles in the sagittal plane. So this is off midline. So this is, let's say, the lateral part of the uvula over here, and this muscle coursing towards the posterior pharyngeal wall is the palatopharyngeus, and this one is the palatoglossus. So I think by now the anatomy of the tonsillar region should be clear. Is there something else I want to tell you or show you? Yes, it is this very fine mucosal recess called the glossotonsillar sulcus. And what is the glossotonsillar sulcus? It is a very small mucosal groove located between the base of the tongue and the palatine tonsil. It's actually often not visible or not clearly visible on imaging studies because the mucosa lies completely opposed to one another. Here we can kind of see it because we see some air lining it, but in a lot of cases you can't really see it. So why is it important? Why am I showing this to you? Well, because it's important to understand tumor spread, because by way of this sulcus, a tumor can extend from the oropharynx to the base of the tongue, because it's a mucosal groove or a mucosal sulcus connecting these two structures, or it can spread from the base of the tongue to the oropharynx. And this is important for tumor staging because an oral cavity tumor or an oropharyngeal tumor often or can have different prognosis and treatment strategies. So That's why I'm illustrating it. That's why I believe you should know there is a thing called the glossotonsillar sulcus. And even though we can't see it in normal situations, when you see a large tumor involving both the tongue base and the oropharynx, you know that this tumor has to have spread from either tongue base to oropharynx or the other way around by way of the glossotonsillar sulcus. And when it comes to entities, I believe you should know, without going into detail, because this is about anatomy, not pathology, you should know, or you should not pathologize palatine tonsils that are enlarged as part of normal physiological hyperplasia, as we can often see in children and even adolescents, but which generally disappear with increasing age. So this is something we shouldn't pathologize, and we see like these symmetrical soft tissue structures located in the tonsillar fossa on both sides. And of course, there's a clear difference with oropharyngeal carcinoma, a tumor that we will not see in children, but in adults, generally adults who have a drinking problem and who smoke. And in that case, the tumor or the abnormality will be asymmetrical. And keep in mind that the tonsillar fossa is the most common subsite for oropharyngeal carcinomas. So just like the Rosenmüller fossa and nasopharynx is the predilection site for nasopharyngeal carcinomas, the tonsillar fossa is the most frequent site for oropharyngeal carcinomas. I'm showing you some infectious entities as well involving the tonsillar region. This is a person with, bilateral tonsillitis. In tonsillitis, the tonsils will be enlarged and enhancing. The difference with physiologically enlarged tonsils can sometimes be difficult, but well, you will often have clinical symptoms, of course. And a person with just enlarged palatine tonsils, it's often an incidental finding. And someone receiving a CT for another reason, they will be enlarged and they will have some kind of striated appearance in case of tonsillitis, as we can clearly see in this patient over here. Next stage in a tonsillitis is the development of an abscess, which we call a peritonsillar abscess. And if this infectious process can spread beyond the fascia lining the oropharynx, it can involve the parapharyngeal space, or in this case, the retropharyngeal space. So when evaluating tonsillar infections, know that they always start as tonsillitis, that they can evolve into an abscess, and if the pathological process continues, they can involve other neck spaces, even the retropharyngeal space, which is the worst space, because when the danger space gets involved, your patient has the risk of developing mediastinitis, which is lethal infectious disease. Let's move on from the tonsillar region to the soft palate. This is the uvula. So once again, when we look inside the throat and of a person and let him or her say ah, we will see this fleshy protrusion hanging in the back. This is an extension of the soft palate, and here we see the anterior and the posterior tonsillar pillars and the tonsillar fossa, but no mysteries there anymore for us. What is the soft palate? Well, the soft palate is basically a soft tissue structure hanging at the back of the hard palate. The hard palate is a bony structure. It forms the superior surface of the oral cavity. And then we have the soft palate, which is a cape-like soft tissue structure attached to it. The uvula is basically a conical extension of the tip of the soft palate, and it is composed of two intrinsic uvular muscles called the uvular muscles. This is a pathological specimen of the soft palate, and what do we see here? Well, it is lined by epithelial cells on the oral cavity or on the oral surface. Those will be what was I going to say? There's a difference between the type of cells you have on the oral surface and the nasal surface. On the nasal surface, we find more respiratory type epithelial cells, while it are more oral cavity-like cells at the oral level. That's not that important right now. So we have epithelial cells lining the soft palate. Then in the submucosa, we have minor salivary glands. So a tumor type that you can encounter in the soft palate is, well, of course, once again, squamous cell carcinoma, when the tumor originates from the epithelial cells, but also minor salivary gland tumors can originate in the soft palate. But the core of the soft palate is basically a group of muscles. So when we look at the core of the soft palate, what do we see? We see muscles which are attached to a central aponeurosis. So the soft palate, if you think about what is that structure exactly, it's basically some kind of muscular fibrous unit. And it is composed of 4 extrinsic muscles and 1 intrinsic muscle. And each of those muscles we've already discussed actually in this presentation and a previous presentation on the nasopharynx. So we have 2 muscles that are associated also with the Eustachian tube, the Levator veli palatini muscle, which is responsible for the elevation of the soft palate, and the Tensor veli palatini muscle, which is responsible for tension of the aponeurosis of the soft palate. And when these muscles contract, the Eustachian tube will also open, as you remember from the presentation on the nasopharynx. And then we have 2 muscles constituting the anterior and posterior tonsillar pillars, namely the palatopharyngeus and the palatoglossus. Then we have 2 intrinsic muscles and the uvula called the uvular muscles. Okay, what is the function? So this we already said. So the soft palate is basically a midline aponeurosis with interweaving pairs of muscles. So what is the function of the soft palate or of the muscles in the soft palate? They elevate and tense the soft palate during swallowing and speech, and this closes the nasopharynx during swallowing. So there is no regurgitation of fluid or food from the oral cavity into the nasal cavity. And when we do that, we simultaneously open the Eustachian tube and the middle ears get ventilated. This is a patient who received a swallowing examination. This is in rest and the quality is low because we do that low dose. But this here is the nasopharynx, and we see contrast lining the tongue and the oral cavity, and we see that in normal situation at rest, the soft palate basically borders the tongue and closes off the oral cavity. When we swallow, however, the oral cavity, and then we get, there's a free passageway from the nasal cavity to the pharynx for air. When we swallow, however, we get an elevation of the soft palate, and it makes contact with the posterior pharyngeal wall, closing off the nasal cavity from the oral cavity. And this will allow food and drinks to go from the oral cavity to the esophagus without regurgitation into the nasopharynx. Okay. Let's now examine the anatomy of the soft palate muscles and the coronal plane. So here we have the Torus Tubarius of the nasopharynx. This is the Levator veli palatini muscle, which you remember from the presentation on nasopharyngeal anatomy. And here we see the soft palate. This is another patient. And we see that the Levator veli palatini muscles form some kind of sling. So when they contract, they will elevate the soft palate. This is another patient, just for practice purposes. We see the same things, the Torus Tubarius, we see the Levator veli palatini attaching to the uvula and the aponeurosis of the soft palate. We see that there is tissue of the soft palate which has different signal characteristics. This is the non-muscular part of the soft palate. So the soft palate also contains submucosa with a lot of some fatty tissue and some minor salivary glands and so on. So this is that other component. We also see, indicated by the arrows, a very fine dot laterally of the Levator veli palatini muscle. This is the Tensor veli palatini muscle, which is a lot smaller and more difficult to see than the Levator veli palatini muscle. And here we have a muscle coursing from the soft palate to the tongue. This is the palatoglossus muscle. And here, we see the actual tongue indicated in red. And if you look at these structures, you can also recognize an X shape a bit, and we see like the sling-like morphology of the soft palate muscles in the soft palate. This is an axial image, and the morphology of the soft palate is a bit more difficult in axial images because, well, the soft palate slopes downwards, so it's we're not able to visualize it in one plane in the axial. Here we see part of the tongue, and this tissue located behind it is the soft palate. We can recognize here the uvula. Yeah, we even see these muscular structures. And this is probably the Levator veli palatini, or is going to be the Levator veli palatini. And then we have tissue with different signal characteristics. So this is the non-muscular tissue of the soft palate. And you will see, and this can be a bit confusing on actual images on CT and MRI, the soft palate in rest immediately lies against the back of the tongue. So we don't see air between those. So we have like these soft tissue structures lying next to each other, or on top of each other. We have the tongue here, and then the soft palate lying immediately on top of it, sealing off the oral cavity, which can make actual images sometimes a bit more difficult because you don't really understand what you're looking at. Once again, here we see some partial volume of the tongue located against the hard palate. And at the back of it, we see the soft palate, and we can recognize the uvula, which has different signal characteristics, because the uvula is basically composed of two muscular structures, the uvular muscles, and we see the Levator veli palatini forming a sling going to the uvula. Okay, and that concludes the soft palate. We're ready to talk about the tongue base now, because as already said, the tongue can be divided in two components. We have the oral tongue located in the oral cavity and the tongue base located in the oropharynx. The tongue base is the posterior third of the tongue. It is the part of the tongue located behind the terminal sulcus and the circumvallate papillae, structures that we cannot recognize on images. So what do? We draw a line from the back of the hard palate to the hyoid bone, and the part located behind that, we say, well, approximately this is the tongue base or the posterior third of the tongue. We also have a recess located behind the tongue base and the lingual surface of the epiglottis called the vallecula. And basically, this is not one recess, these are two recesses, paired recesses, as you can see on this axial image. So we have two of them. So this is the sagittal plane, and we recognize here the epiglottis. And I'm just going to repeat myself. The epiglottis is not part of the pharynx. The epiglottis is part of the larynx. And then we have this recess between the epiglottis and the tongue base. This is the vallecula. And this is part of the oropharynx. So we can consider this part of the tongue base. Here we see the paired vallecula. We see the epiglottis here in yellow. And this small line is called the median glossoepiglottic fold. So it's a bit of tissue connecting the tongue base with the surface of the epiglottis. And here we have the Pharyngobasilar folds on both sides, connecting the lateral pharyngeal walls at the level of the tongue base with the surface of the epiglottis. And so we get like these two recesses located over here. We can also see it quite clearly on this magnified view. This is the hyoid bone, and the epiglottis actually has two components. We have a suprahyoid part, which is free, and we have a fixed infrahyoid part, as you can see here. And we see here also on the magnified, this magnified view, the glossoepiglottic fold and the pharyngoepiglottic folds. It's not completely visible over here. If we went one slice lower, we would have seen the left fold as well, but I wasn't able to visualize them in the same plane in this patient, and these line both vallecula. What we can often see, especially in younger patients at the level of the tongue base, is this. We see here the tongue base. You will recognize this if you've seen the video on oral cavity anatomy, so I'm not going to repeat these structures, but this here we see tissue. This is not, the tongue is composed of muscles. We see here the typical dark signal of muscular structures. This tissue has different signal characteristics. This is not muscular tongue, What is it? These are the lingual tonsils. So once again, we are dealing with lymphoid tissue, part of Waldeyer's ring that can become hyperplastic, especially in younger patients. And it's very important to not confuse this with pathology. Here we see a patient with lingual tonsil, enlarged lingual tonsils. The patient also has enlarged lymph nodes on the right side of the neck. That was because the patient had a tonsillitis, but this here is not part of a tonsillitis. This is an enlargement of the lingual tonsils, as you can often see in children or younger patients. These are aggregates of lymphoid tissue. They are often symmetrical and enhancing and can give the tongue base a somewhat irregular nodular surface. If you're dealing with children and you see this is going to be lingual tonsil enlargements. It can persist in adults, but it is less common there. So there you, especially in older patients who are smokers and drinkers, you have to consider the possibility of tongue-based carcinoma, but most of those will be asymmetrical, but nothing is impossible. So, okay, lingual tonsils, and it brings us to a brief discussion on tongue-based pathology, very short. But what you should take with you after this presentation is do not pathologize lingual tonsil hypertrophy, which is symmetrical and more commonly seen in children. Do not mistake that for tongue-based carcinomas, which are often, well, you have a different patient group, older patients, smokers, drinkers, often asymmetrical. The tongue base is the second most common subsite for oropharyngeal carcinoma after the tonsillar region. And you can also have tumors in the vallecula, which can be considered part of the tongue base. The difficulty with a tumor in the vallecula, as we see here, so this is the normal vallecula, and this is a vallecula completely obliterated by enhancing tissue because there's a tumor there. That's, well, what's the origin of the tumor? If the tumor originates from the base of the tongue, you're dealing with an oropharyngeal tumor. If the origin is the epiglottis, which is theoretically possible, we are dealing with a supraglottic laryngeal tumor. In this case, I would feel inclined to say this is going to be a tongue-based tumor, completely obliterating the vallecula, but it can be very difficult and sometimes more a distinction based on gut feeling than hard arguments. Then finally, the last subsite of the oropharynx, the posterior pharyngeal wall. When discussing the tonsillar region, I told you that the lateral wall of the tonsillar fossa is formed by the superior constrictor muscle, and this muscle continues in the posterior pharyngeal wall. So this is basically a wall composed of interweaving fibers of the superior and middle pharyngeal constrictor muscles covered by mucosa. And this muscle, as we have seen in the first presentation on the pharynx, is necessary for swallowing and propels food from the oral cavity or the oropharynx into the hypopharynx and esophagus. And normally it's very, very smooth and thin. As you can see on these extremely magnified images, this is the posterior oropharyngeal wall. So a very thin T2 hypointense layer covered by mucosa. And this is on a sagittal T1 weighted image, so we see a very thin layer of tissue over here. Tumors here are, well, it's the least frequently involved subsite for oropharyngeal tumors, but not impossible. So if you see this was a squamous cell carcinoma arising from the posterior pharyngeal wall. Because tumors are very uncommon there and well, all tumors start small, they can easily be missed if you do not look for them. So always give the posterior pharyngeal wall a glance when interpreting a CT of the head and neck or an MRI. And with that, I think we're ready for the final part of our discussion on imaging anatomy of the pharynx. Let's now talk about hypopharyngeal anatomy. So welcome to the last presentation on imaging anatomy of the pharynx. And in this presentation, we're going to talk about the anatomy of the hypopharynx. The hypopharynx is the lowest part of the pharynx, extending from the tip of the epiglottis. And once again, the epiglottis is not part of the pharynx, it is part of the larynx, extending from the tip and the posterior surface of the epiglottis to the inferior surface of the cricoid. I hope I pronounced it correctly. Cricoid. cricoid, whatever, you know what I mean, posteriorly and located posteriorly of the larynx. And the hypopharynx serves as a passageway for food to the esophagus. The hypopharynx is probably the most difficult one of the components of the pharynx. It is actually quite small, quite dense, and from an anatomical point of view, strongly related with the larynx lying anteriorly of it. So in a lot of textbooks or articles, you see that the anatomy of the hypopharynx and the larynx are often discussed together because that kind of makes sense to do from an anatomical point of view, despite the fact that they belong to different components of the head and neck or different compartments. Me personally, I don't like to do stuff that makes sense, and it's an attitude that explains a lot of my decisions in my personal and private life, but enough about that. Let's focus on the hypopharynx and discuss it separately from laryngeal anatomy, and I'm going to make something about laryngeal anatomy for a future presentation. But that's work in progress. Let's start with defining the borders of the hypopharynx. So what are the borders of the hypopharynx? As already said, the superior border is the tip of the epiglottis belonging to the larynx, and the inferior border is the inferior surface of the cricoid cartilage. And here this arrow helps you see it because it's located quite inferiorly on this image as well. The posterior border is formed by the posterior hypopharyngeal wall. The anterior border is formed by the laryngeal inlet, so basically the opening from the hypopharynx to the larynx, and this kind of explains why laryngeal and hypopharyngeal anatomy are often discussed together. And then the lateral borders are formed by the piriform recess, which are located on both sides of the larynx. So we see the piriform sinuses, says here recess, correct name is sinus. So we see them here located on both sides of the larynx. The hypopharynx has three subsites. As already said, we have the pyriform sinuses, we have the posterior wall of the hypopharynx, and this is a quite difficult one to actually visualize, we also have the postcricoid region, which is the anterior mucosa located posteriorly of the cricoid. So basically, if you look at the middle image over here, the postcricoid region is this small area of mucosa located along the cricoid cartilage, but not the posterior mucosa, only the anterior mucosa. Okay, I'm going to illustrate that in a bit more detail later. Let's start with the piriform sinus, which is no doubt the most important structure of the hypopharynx when it comes to oncological imaging, because most hypopharyngeal carcinomas originate in the piriform sinus. So these are pear-shaped recesses located on both sides of the laryngeal inlet. So the air-filled structure in the middle, that's not a hypopharynx, that's the larynx. Important distinction. And they are important areas from a clinical point of view because, on the one hand, the pyriform sinuses are areas where you frequently get foreign body impaction. And, as already said, they are also an important site for the development of hypopharyngeal carcinomas. Now, this is an image of the border of the laryngeal inlet as seen by a laryngoscope. And yeah, it's possible that you don't recognize anything on these images, so let's help you. I'm showing you this because it will help you understand what you see in your images. Over here, we see the laryngeal surface of the epiglottis, so basically the back surface of the epiglottis. And the epiglottis can, when we swallow, actually tilts inferiorly to close the laryngeal inlet, so we don't aspirate, and no food or drinks enter the larynx. Anyways, enough of that. This is the laryngeal surface of the epiglottis, and here in the depth we can see the vocal cords, and the part of the glottis located underneath it is called the subglottis, also visible here. Then these somewhat, how should we describe this? these structures, I'm going to call them because I can't find a suitable adjective in English. Nothing pops to mind. Are the arytenoid cartilages covered by mucosa, of course, and we have a mucosal fold going from the arytenoid cartilages to the pharyngeal wall called the wall of the epiglottis called the aryepiglottic fold. Now, posteriorly, we find the hypopharynx, and located in the depth is the entrance to the esophagus. And these recesses over here, located on both sides of the aryepiglottic fold, or the pyriform recesses. With all this in mind, let's take another look at our images and try to visualize all these structures. So once again, we see the laryngeal inlet over here with the pyriform recesses or pyriform sinuses located on both sides. The medial wall of the pyriform sinuses is formed by the aryepiglottic fold, so the mucosal fold connecting the arytenoid cartilages with the epiglottis, and the lateral wall is formed by thyroid cartilage. If you look at a magnified coronal image, this here is this is the right pyriform sinus. This here is arytenoid cartilage. Over here we see the hyoid bone, and this is the aryepiglottic fold forming the medial wall of the pyriform sinus, and the lateral wall is formed inferiorly by thyroid cartilage, and then we have a thin membrane connecting thyroid cartilage with the hyoid bone, and this is called the thyrohyoid membrane. This is very thin and also allows the passage of certain neurovascular structures, including the recurrent laryngeal nerve. Now, the pyriform sinus is, as said, the most frequent site for hypopharyngeal carcinomas. These often present late. When they are discovered, there is often advanced submucosal spread, which can extend into the larynx or even the esophagus. And because this region has a rich lymphatic supply, there are often lymph node metastases, as we can also see in this patient over here. And from a clinical point of view, or from a radiological point of view, in advanced cases, it can become quite difficult to make the distinction between a hypopharyngeal tumor that has spread into the larynx or a laryngeal tumor that has spread into the hypopharynx. I will talk more about that in a future presentation on staging of head and neck pharyngeal and laryngeal tumors. Then we have the next subsite, the posterior pharyngeal wall. This is basically the mucosa-lined back wall of the hypopharynx. Here we see the cricoid, and the inferior surface of the cricoid is basically the inferior border of the hypopharynx. Here we have the superior border formed by or indicated by the tip of the epiglottis, and then the back is the posterior pharyngeal wall. What do we find there? Constrictor muscle, as we mostly find in the posterior pharyngeal wall. In this case, it's going to be probably parts of the middle and inferior constrictor walls. And behind it, we have the retropharyngeal space, prevertebral muscles, and vertebra. So a tumor located in the posterior pharyngeal wall will tend to invade these underlying spaces. We also have the postcricoid region, and this is a difficult region to understand and visualize. I also indicated here the aryepiglottic fold, which you can see above the cricoid in this patient. And what is the postcricoid region? Well, it's a region located behind the cricoid. It's basically the mucosa behind the cricoid, but not all mucosa, the anterior mucosa, because the posterior belongs to the posterior hypopharyngeal wall. Why do we make this distinction? It is made for oncological purposes, because tumors that originate from the postcricoid region behave different than tumors originating from the posterior hypopharyngeal wall, despite the fact that it is often difficult to make the distinction in this very small region. So it is located in front of the hypopharyngeal lumen and the mucosa lying the posterior hypopharyngeal wall, and inferiorly, this is continuous with the upper esophagus. So tumors in this region will often spread into the cervical esophagus. This is a magnified axial image. Here we see the cricoid, And here we see the posterior pharyngeal wall, and this is then the anterior mucosa posteriorly of the cricoid. This is the postcricoid region. Now, basically we infer the location, right? Because this just blends the mucosa of the postcricoid region and the posterior hypopharyngeal wall. They just opposed, they just lie immediately on top of each other, so we can't really see the difference between the two. Even when we do high resolution MRI images, which I'm showing you an example of. This is a very high resolution image showing you the cricoid. This is the posterior cricoid arytenoid muscle. And then we have a very thin line of mucosa lining that. That's the postcricoid region. And posteriorly of that, we have the posterior hypopharyngeal wall. If you would scroll down a little bit, we will stumble upon the cervical esophagus. Okay, from a practical point of view, it's important that you realize that this distinction exists and was made for oncological purposes. But if you encounter a tumor in this region, it will always be difficult to make a distinction between a tumor originating from the anterior mucosa or the posterior mucosa. Here we see the cricoid. We see a mass involving the hypopharynx in the postcricoid region, but did the tumor really originate from the anterior mucosa? Always difficult, sometimes very subjective. Opinions can differ. In this case, I would say no. And why is that? Because I would assume that a tumor originating from the anterior mucosa would involve all the mucosa and basically be situated along the entire back of the cricoid. This is not the case here. Here we see a tumor that, in my opinion, when looking at the way this tumor has grown, probably originated somewhere along the left side of the posterior hypopharyngeal wall. It kind of makes sense, so that was my interpretation of this case, but I admit that it can be extremely difficult. And very important is also to look for the extension of the tumor in other spaces, or in this case, in the upper esophagus. Okay, this concludes my presentations on pharyngeal anatomy. I said a lot about pharyngeal anatomy. Let's summarize. What do I want you to remember of these, when you combine them, presentations, probably totaling almost 2 hours on pharyngeal anatomy? I hope that if you watched all of these, that you're quickly able to recognize all the important structures of the nasopharynx, that you immediately recognize that this is the nasopharynx, because we see here the typical Torus Tubarius, here the impressions caused by the longus capiti or colli muscles, and that you see or immediately recognize Rosenmüller's fossa, located posteriorly of the Torus Tubarius and the predilection site for nasopharyngeal carcinomas. I hope that when you look at the level of the oropharynx, that you immediately recognize the components of the tonsillar fossa. We see here the uvula, which is also part of the oropharynx. We see here the tonsillar, the palatine tonsils, and we see the anterior and posterior tonsillar pillars formed by the palatoglossus and palatopharyngeus muscles, respectively. We even see the superior constrictor muscle, which forms the lateral wall of the tonsillar fossa and also continues as the posterior pharyngeal wall. Also remember that the tongue base is part of the oropharynx and not of the oral cavity. We also have seen that there's a peritonsillar space, and this is the location for peritonsillar abscesses. When it comes to the hypopharynx, you will at a glance recognize now the pyriform sinuses located laterally or posterolaterally of the laryngeal inlet. So this is the larynx. And at the level of the cricoid, know that this is a quite complex region, because you find two subsites here. You find the postcricoid region, which is the anterior mucosa of the located behind the cricoid, but also part of the posterior pharyngeal wall, which is the posterior mucosa in this region. Be able to make a quick distinction between things you shouldn't pathologize, like nasopharyngeal adenoid hypertrophy in the nasopharynx, and which is most frequent in children, from a nasopharyngeal carcinoma, as you can see over here, which will be asymmetrical and generally seen in older patients. The same applies to the oropharynx, where you should make a distinction between benign palatine tonsil hypertrophy, which is most pronounced in children and adolescents, but will decrease with increasing age. And do not mistake that for oropharyngeal carcinomas, which will be seen in older patients, smokers, drinkers, and will be asymmetrical. The same is true for the lingual tonsils, where you shouldn't mistake a lingual tonsil hypertrophy seen in children with a tongue-based carcinoma. Okay, and this concludes my presentation on imaging anatomy of the pharynx. I use several references for making this presentation. It's not that I'm so knowledgeable out of my own. I have to look a lot of things up. I continuously learn new things by making these presentations, and I learned a lot from this excellent reference article on anatomy of the pharynx and cervical esophagus, and I recommend it greatly. Published in Neuroimaging Clinics of North America in 2022 by colleagues Dr. Karaos Manoglu and Dr. Ozgun, both working in Chicago. No, one of them working in Ankara, Turkey, and the other one working at the University of Illinois Hospital in Chicago. Dr. or Professor Ozgun was very nice to send me a copy of this article because I had no access to Neuroimaging Clinics of North America. Really appreciate this. Can't thank you enough because it's a beautiful article. It's a very helpful article. There are a lot of others out there. Use the references in this article to deepen your knowledge. I recommend it greatly. And I would like to thank once again the authors both for publishing this excellent article and sharing it with me. So that concludes my presentations on imaging of the pharynx. Any questions, comments, or feedback, leave a comment, question, or some feedback in the comment section, or send me an email, neuroradiology.online@gmail.com. I am way behind on replying to my emails. My apologies for that. I do my best to reply to everyone, so if you haven't received a reply, even though you wrote me an email, it will probably come. Just be patient. So every now and then I make some time to go through all those emails and actually reply to all of them. So thank you very much for watching.